Hello, and welcome back to part 4. Let's keep trucking along. Common complications that preterm babies suffer with. One of them is apnea of prematurity, or AOP. There's something called central apnea, which is due to neurological immaturity. And then there's obstructive apnea, which is due to a blockage of airflow. Preemies generally have central apnea. Retinopathy of prematurity is a little bit different. It causes altered retinal vascularization. It is greatly affected by OT, O2, or oxygen. What happens is when babies are on an event and you have these rapid swings in their oxygen that go from, say, 30% on the vent to 40% to 28% to 50% O2, and you have these big swings all the time, it causes the blood vessels in the back of their eye to just go crazy, and they go, the back of the eye, the retina just gets too much vascularization, and then it gets heavy and it pulls on the retina. It causes retinal detachment. It can lead to blindness. This is why Stevie Wonder, pop singer, is blind, because he was a preemie and he developed retinopathy of prematurity. More cocktail trivia for you. Gastroesophageal reflux is another common complication. Babies have reflux because they have poor esophageal sphincter tone, and it causes laryngospasms. It also causes A's and B's for babies. A's and B's, again, are apnea and bradycardic events. And then preemie babies they are at risk for developmental delays such as speech and hearing impairments, oral aversions, which means that they don't want anything in their mouth, not a pacifier, not food, not a utensil, nothing, which makes feeding them a little bit problematic. They usually end up with a G-tube. And of course, behavioral issues such as ADHD, and we've already kind of talked about that. Again, I want you guys to be aware that premature babies are immature. They are not just a mature baby in miniature form. They are immature. They cannot handle much stimulation. Their sensory circuits overheat, so to speak. But when they're bombarded with sensory overload, they just simply shut down. This is why in the NICU, hopefully, you all were able to observe dim lights. We put covers over our isolettes. We lower our voices. We try and limit the noise. We keep babies contained, which means we keep them flexed. We keep them in a midline orientation when we position them. We try and mimic the womb as much as possible. We provide comfort. It's a very gentle touch and a very gradual movement, because these babies are not even supposed to be handled by human hands at all at 28 weeks. They're supposed to be safely tucked inside their mama, and they're not. And then we do offer non-nutritive sucking, because does provide them with a source of comfort. It is important as the NICU nurse to facilitate and teach a parent how to safely and properly interact with their preterm baby. Care ideally needs to be cue-based. Some of the signs and symptoms that a baby will give you if they have sensory overload would be finger splays, that the baby cannot make eye contact with you, they look away or just close their eyes. They will develop hiccups, they will desat, and then they will eventually breathe. One of your most important jobs as a NICU nurse is to promote parent bonding. These babies are not going home with you, they're going home with their parents. And the sooner that you can help the parents become comfortable in taking care of them, the safer and the better outcome it will be for the baby as well. So encourage the parents to visit. Encourage them to touch their baby and do as much of the baby's care as possible. Let them hold their baby. Skin to skin is best. Call parents with updates, good and bad news. I've called parents just to tell them, hey, your baby just took a bottle for me, and your baby did a great job. Let the parents personalize the baby's bed space or their room. Encourage them to make little scrapbook pages. Encourage them to bring little pictures in to decorate the bed space, whatever it is they need to do. And also, you need to encourage parents to take some time for themselves too. When parents are there, it's a good time to say, you know what? Why don't you guys go on a date before you bring the baby home? Because you probably won't go out on a date for a while once you do bring the baby home. Why don't you go out to dinner? Why don't you go see a movie? Why don't you go do something, just the two of you, try and reconnect and try and process all of this and take a night off from worrying and stressing about being in the NICU. Best thing to do is to involve the parents in the baby's care as much as possible. You have to teach the parents how to care for their own baby. Be a good listener, reassure mom and dad that they are not being punished and that they didn't do anything wrong. Allow siblings to visit as per the hospital policy. Encourage families to talk to other NICU families for a source of support because the fellow NICU families know exactly what they are going through. So preparing a baby to go home from the NICU involves teaching the parents about activities of daily living. What are the ADLs for a baby, you ask? Well, teach the parents how to make the milk, teach them how to bathe the baby, how to use the bulb syringe, how to take a temperature, make sure they know not to smoke around the baby. May go over safety issues, go over circumcision care, all the types of discharge teaching you would do for a term baby, go over that for a preterm baby as well. Also, we strongly encourage parents to always take an infant CPR class before going home. In the unlikely event that they might actually have to administer CPR. Make sure that the parents are comfortable with and know how to correctly draw up and administer any medications such as vitamins and iron. Make sure that they know when to call the doctor. Help the parents and make follow-up appointments. These are just some of the people that may be included. These won't be included for every baby, but they could be included. If you had a 24-week preterm baby, they very well could have to follow up with the pediatrician, the pulmonologist, the cardiologist, the ophthalmologist, the neurologist, possibly with the pediatric surgeon, with PT, OT, or the speech language pathologist, and then possibly with home health. In addition to all this, getting a baby ready to go home, it takes a good solid, 2-3 days for the NICU nurse to pull all this stuff together because the baby also needs to have a hearing screen, a car seat trial, and the pulse ox screening to check and rule out for critical congenital cardiac heart defects. Now, these next couple of slides are really not in your book, but I wanted to include this information because as nurses, we like to look ahead to the future and anticipate problems and anticipate complications. So most of the time when babies are born, they come out, they take their first breath, and they transition very well. Preterm babies do not always do that, and term babies do not always do that if they have certain risk factors. So what I've done here is just list who some of the infants are who would be at risk for needing resuscitation after birth. And by resuscitation, I mean either ambu bagging or complete CPR. And this is not an exhaustive list either. Resuscitative efforts are required by about 5 to 10% of all newborns to start breathing. Ask yourself, is the baby term? Is the baby breathing or crying? Does the baby have good muscle tone? If a baby comes out and does not start breathing and does not begin a transition, step one is to dry, stimulate, and keep the baby warm. You're going to position the infant on their back, extend the neck upward and so that the baby's in a sniff position. You want to assess the airway, breathing, and circulation. Evaluate the heart rate and the respirations. Is the heart rate greater than 100? Is the baby trying to gasp? Is the baby trying to breathe? Or is there no respiratory effort at all? If the baby is trying to breathe, you can administer oxygen, maybe by some blow-by. You might need to do, if the baby is not trying to breathe, you might need to provide positive pressure ventilation, or PPV, aka ambu bagging. And if the baby is still not doing anything and you have assistance there, they may choose to just go ahead and intubate the baby right there in the delivery room. If the heart rate is less than 60, well, we'll get back to this in a minute, but you may have to begin chest compressions, and then you may have to administer resuscitation medications as well. In the process of resuscitating a baby, start with PPV if there is apnea or gasping, and if the heart rate is less than 100, or persistent central and low O2 sat, despite low by 100%. So basically, bag the baby if they have a low heart rate, if they're apneic or gasping, or if they have a low O2 sat, despite having 100% blow by near. You want to bag a baby at a rate of 40 to 60 breaths a minute. That's usually not too hard, because most of the time if you're having to bag a baby, you're probably even going to bag too fast because you're so nervous. Use the pressure gauge on the ambu bag so that you don't pop a baby's lung and give them a pneumo. If you are bagging, you will need to place an OG tube down the mouth into the stomach and then open it up to help vent the stomach. If the heart rate is less than 60 after 30 seconds of positive pressure ventilation, then you need to begin chest compressions. You really need to get the baby intubated if you're going to do chest compressions to coordinate between the respirations and the compressions. There are two methods for compressions, the thumb encircling or the two fingers on the chest. If the heart rate remains below 60 despite 45 to 60 seconds of compressions, then the neonatologist will order you to go ahead and start pushing drugs. You can use the umbilical vein, and you can actually push epi down the ET tube if you have to. You may have to give some bicarb to treat the acidosis that will likely occur from lactic acid buildup. You may need Narcan if you know the mom's history. If shock develops, the baby needs blood volume expanders such as normal saline or lactated ringers. Whole blood is needed if there was a fetal hemorrhage or fetal anemia, or something like a placental abrasion. Packed red cells can also be given for hypovolemic shock. And this slide just shows a baby receiving positive pressure ventilation. Clearly, this baby is just being used for demonstration purposes, because if you look, the baby has excellent skin color, looks very pink and very well perfused with oxygen. But these two pictures do show the two thumb encircling technique as well as the two finger technique for doing CPR. The other thing I want to remind you is when you're doing CPR, don't forget to keep the baby warm and dry. All right, we'll shift gears again here. Respiratory distress syndrome, abbreviated by saying RDS. Basically, it means there is a lack of or inadequate surfactant. It also can be called hyaline membrane disease. Basically, all infants are at risk for this. Each breath is harder than the last, which is tricky, especially in a preterm baby, because again, if each breath is harder than the last breath, it takes even more energy for every single breath. And do they have glycogen reserves? Do they have glycogen stores? No, they don't, because they're a preemie. Signs and symptoms of RDS. This is important for you guys to know. Cyanosis, kind of. It's usually just more pallor and paleness. Tachypnea, that's your biggie. Babies are supposed to breathe between 40 to 60 times a minute. If they are breathing greater than 60, that is tachypnea, and that's a sign of respiratory distress. Grunting, that's a huge one. Babies grunt a lot after they're born. Nasal flaring, retractions, or apnea. all signs of RDS. You should absolutely know those. These are just some of the common RDS manifestations. This is how it actually presents, what it looks like clinically. So I'll have you read through this slide. Let's challenge you. This is a typical preemie X-ray. So what do you think the arrow number 1 is pointing to? If you guessed PICC line, you are correct. The PICC line is going in, and it is clearly it's in the heart. It looks like it's in great placement for the superior vena cava, the SVC. Arrow number 2 is pointing at the tip of the ET tube. So when babies are intubated, they get a daily X-ray so we can confirm placement of that ET tube. Arrow number 3 is pointing to the OG tube that's down in the baby's stomach. Anytime a baby is intubated, they must have an OG tube inserted as well, so that there is a way to decompress the stomach. This is just a reminder for you and for blood gas evaluation. The chart at the bottom shows you what is normal for an arterial and normal for a capillary, and then everything is just sort of summarized for you above. So how do we manage respiratory distress syndrome? Well, they will do an X-ray. They usually look at it and say, yep, it looks like classic RDS. So they will intubate the baby. The nurse will administer, well, the nurse and respiratory, both is sort of a joint effort. Surfactant is administered. And then you wait. And then usually within 12 hours, you can either extubate the baby or you will administer a second round of surfactant, and 12 hours from that, hopefully extubate the baby after that. We like to get babies off the vent within 24 to 48 hours, if possible. This slide just goes over clinical assessments associated with RDS, and you can read through those. And there's a great table in your book that I referenced as well. So I know we've talked before about transient tachypnea of the newborn. Again, same story, usually results from an excess fluid in the lungs. Risk factors include those late preterm or those near-term babies, so those like 35 to 37 weekers. If the mother has diabetes and asthma, if the baby is a boy, if the baby has macrosomia, if it's a C-section with or without labor, poor urine perfusion, prolapsed cord, and or breech presentation are all the risk factors for TTN. Care for TTN involves initiating oxygen therapy. Oftentimes respiratory will come and they can provide CPT for a baby, and that kind of helps break up those secretions, helps facilitate with the reabsorption of the fluid. An oxy hood may be required. That's what the baby has going on in the picture below. Intravenous fluids will be provided for fluid electrolyte balance and for, well, usually it's D10 that started, for their baby's glucose needs. We will restrict PO feeds until the respiratory status improves, and we do that because the baby has an increased risk of aspiration due to the tachypnea. When you're breathing 80 to 90 times a minute, it's kind of hard to suck, swallow, and breathe a PO feed, right? Aspiration syndrome is just pretty much that. It's the presence of meconium in amniotic fluid. It is considered to be a sign of fetal distress. Babies poop in response to hypoxia. Fluid can be aspirated into the lungs, basically in utero, or during the first few breaths after delivery. Poop in the lungs causes mechanical obstruction in the airways. Air can get in, but it can't get out. So alveoli become over distended, and that sets babies up for a pneumothorax. Clinical manifestations or signs and symptoms of meconium aspirate syndrome would be the presence of meconium below the cords. If a baby is born and they are vigorous, which means they come out screaming, then we just wait and watch them closely and assess them for signs and symptoms of this. If a baby is known to have already passed their meconium in the womb, aka, well, and we know that when they check mom and they find poop on their fingers, or there's green amniotic fluid. If the baby comes out and the baby is not vigorous, that is the one time you do not stimulate the baby. They will immediately take the baby over and usually intubate and try and vacuum out the airway before the baby takes that very first breath. Fetal hypoxia can occur days before or even minutes before birth. A sudden increase in fetal activity followed by diminished activity, slowing of fetal heart rate, or weak, irregular heart rate can indicate the presence of meconium-stained amniotic fluid. Distress at birth can cause the babies to have pallor, cyanosis, apnea, a slow heartbeat, low APGARs, respiratory depression, and then their nails and their umbilical cord will be stained green from the meconium as well. Your X-ray findings are listed for you on your slide. But I mean, that's a classic X-ray for meconium aspiration too. This is a hard slide to talk about. Parents really struggle when their children are in the NICU. Lots of times it's important to facilitate the parental adjustment to the infant's special needs. Some parents have acute feelings of grief. They're just sad. When moms have a baby, they're supposed to bring their baby home with them. That's what they've anticipated. That's what they have dreamed of the whole time they were pregnant, is getting to term, having that baby, and then holding that baby in their arms while they're wheeled out to the car in the wheelchair. That's what parents think of. So when parents have to leave the hospital and they've had a baby and their belly is empty and they don't have a baby in their arms, that is oftentimes that first time they leave the hospital without their baby is so hard for moms emotionally. And then you add in all those crazy postpartum hormones when they're already crying a lot and they're already sad and blue anyway. It's a recipe for disaster. Lots of times, if I get a chance when I worked in the NICU, I would tell, the dad or whoever was going to be taking the mom home, I'd pull him aside and say, let me give you some advice. And I would tell them, and I would, tell the moms this too. When it's time for you to go home tomorrow and your baby does not go home with you, don't think about it as leaving your baby behind, because you are coming back again. Think about just going out on a date, because if you went out on a date, you probably would not bring your baby with you. So go, okay, we've got babysitters at the hospital. They're going to stay and take care of the baby. We're going to go out on a date. I said, don't go straight home and go stand in the nursery and sob and cry because your baby is not in the crib. Leave the hospital, go grab a bite to eat, go stop by a park, do a little bit of walking, do something a little fun, and then when you go home, it feels more normal to go home. Lots of times parents will suffer with feelings of guilt when they are at the hospital because maybe they have other kids at home and they feel guilty because they're not at home taking care of them. Guilt when they are at home taking care of the other kids because they're not at the hospital taking care of their newest baby. They also feel guilt and shame because they think, what did I do wrong to make my baby have to be in the ICU? What is wrong with my body? Why couldn't I keep my baby inside until term? Postpartum depression is rampant among NICU moms for those very reasons. They feel like their body has failed them, they have failed their child, and there's nothing worse than that. Lots of times parents suffer with a loss of control. They feel left out. Parents are used to feeling like they are in control of their children. They get to call the shots. They make decisions. And when you're in the NICU, Sometimes decisions are made so fast in order to save a baby's life that parents have to be just told what happened after the fact. And it's not that parents don't agree with those decisions, but they just feel like they got left out of that decision-making process. So, as a nurse, what do you think you can do to help with that? Make sure you keep your parents updated. Call them with updates all the time. When your baby's in the NICU, parents want to hear about everything, especially when they're not there all the time. Call them with good news. You have to call them with bad news, but call them and tell them good news. Hey, your baby just did something so cute today. Lots of times NICU nurses will take pictures and they make scrapbook pages for the parents of good days that the baby has. Sometimes parents will grow to resent the NICU and the other care providers. And it's not so much that they resent an individual nurse, they just grow to resent all the ill feelings they have while they're in the NICU. Because, again, they don't feel like they're in control, they feel like a failure. Now, these feelings, oftentimes, if that happens, you're talking about babies who've been there for, maybe months. Parents just resent the whole process of being in the NICU. They're still always grateful for the care that you're providing, but they just hate being there. They hate having their family split and broken up for months on end. And it's easy for anyone to understand that those feelings usually, in my experience, fade with time once the parents bring the baby home. And then they pretty soon they go, wow, that was a really tough time we had in the NICU for those 3 months we were there. But I don't remember anything necessarily bad. I just remember that it was really hard. And then you need to prepare parents for that. It is truly a roller coaster of emotions. There are days where parents will be so high, like, oh, my baby's doing so good. And the next day the baby will have a bad day, and it's a low, low, low point for the parents as well. Oftentimes parents will struggle with the decision to go back to work when it's time to, because if a mom only has, between 6 to 12 weeks of maternity leave, if the baby's going to be in the hospital for at least that length of time, they will oftentimes say, okay, I'm going to go back to the hospital, or I'm going to go back to work, I'm sorry, and save my maternity time for when the baby actually comes home. And so that's a tough roller coaster too. Families sometimes grieve the loss of the quote perfect birth that they had planned for. Everybody seems to have an idea of what the kind of birth that they want. And the more specific they get in their ideals and their image and their dream, um, unfortunately, it just kind of sets people up for failure sometimes. Sometimes it's a little bit easier if you can just encourage parents to say, you know what, I don't know how it's all going to happen, but let's just shoot for a healthy mom and a healthy baby. Instead of setting it up to, I want the lights to be dimmed, I want no one to talk, I want the baby to come out and immediately be on my chest, I don't ever want to be separated from the baby, I want this. And once you start, specifically prescribing all these things that you want for your quote perfect birth, that tends to be when things do not go that way at all. We'll just say that. If the baby is really early, sometimes the parents may not visit that much in the first few days. And honestly, it's because the parents are scared to get attached to the baby because they don't know if the baby's actually going to survive. When you deliver a baby at 23, 24, 25 weeks, there's no guarantee that that baby's going to make it. There's no guarantee a baby's going to make it ever, but especially in an extreme preterm like that. So parents tend to kind of stay away for the first few days just because they are scared that they will come to the NICU and it's a super scary place, but it's terrifying for them to watch their child struggle just to live, and they just can't handle it. And they don't want to get too attached because they're afraid the baby will die. NICU moms do a lot of blaming themselves. They place a lot of guilt on themselves for the NICU admission. They may be angry towards others. They may resent those who have a baby and go home in a few days. They may look at other moms on the floor who come into the hospital and they have their baby and they go home in 2 days and go, "Oh, I am so jealous of you. How come you get to take your baby home, but I don't get to take my baby home?" Postpartum depression is a major risk. Parents struggle with how to cope with being in a NICU and how to be at home with the other kids. They also struggle with this notion of how are they going to pay for the astronomical cost that the NICU is going to undoubtedly um, incur. When a baby dies, one of the best things that you can do, and babies are going to die, is provide the family with privacy. You need to be extremely patient. Remember, this is the only time that they ever get with this child. So do not rush them. Do not rush them in their way that they are going to say goodbye. You let that mom, you let that dad, you let them hold their baby as long as they need to. Because once the baby goes to the morgue, that's it. They won't get to hold the baby ever again. You can pray with them, and if you don't feel comfortable doing that, you can call pastoral services. And you may want to ask the parents, do you have a pastor that you would like me to call for you, and have them come? You be extremely supportive of the parents while they're going through this. That means if they need, you can offer to go get them a drink of water. You can get them a warm blanket. You can offer to make, some phone calls for them. Most parents don't ever take you up on that. But you support the parents and the family as they're going through this neonatal loss grieving as much as possible. And it's important to provide them with little mementos. Maybe the parent, everything that you can give, everything that touched the baby goes in that box that's possible. So the little hat that the baby wore, you would tuck in there. You would put the baby's little blood pressure cuff. You're going to put their thermometer. If you take and cut a lock of hair, that would go in there. The little dress, I say it's a dress, but the little gown, if you take pictures that the baby wore in the pictures, that would go in there. You can put a diaper in there. You can take a little tape measure and you can mark what the baby's length was, and then cut the tape measure and include that in there. You always want to take footprints and maybe handprints of the baby and put that in there as well. And then ask the parents how they feel about pictures. Sometimes parents want pictures and sometimes they do not. Usually it's a good idea to go ahead and just take pictures, and if parents say they do not want them, you can hand pictures over to pastoral services and they will hang on to them for a year or two. And then if the parents get home and 6 months later they go, "Man, I wish I would have let them take pictures." If they contact the NICU, then pastoral services will have them and they can get those to parents. I've often had nurses say, "Oh, you shouldn't cry." But if you're taking care of a family and they've just lost their baby, you better cry. Because you have to cry. You don't want to cry more than the parents. You don't want the parents to be consoling you. But you're going through something with those families. And I can tell you, I would never want a nurse who couldn't shed a tear over my baby to be taking care of me and my baby who has passed away. They jolly well better be crying if I'm crying. So don't be afraid to let a little bit of your emotions show. Oftentimes when a baby passes away, you can offer, sometimes parents will want the baby to be baptized right before the baby passes away or support is withdrawn. That is always an option. If parents want to give the baby their first and last bath, that is an option as well. And you will let the parents hold and you will let the parents give the baby a bath and bathe them and get them ready. Neonatal loss it is the hardest team that you will ever have to care for. It's so very hard. And you will be completely emotionally exhausted and wiped out at the end of the day when you go home. And if you have children, you'll go home and you'll hug your kids so tight. And you will think, how was I so lucky? What did I do? And you will, not to have to go through this. And you'll be grateful. So just know that those days happen. They're not easy for anybody. But how you handle things really makes a difference for those people who are going through it. So just be very, very tender. Very tender with them. Okay, well, that concludes chapter 25. I hope you found this lecture helpful. Thanks.